There are 4 or 5 conditions which are asymmetric, which will allow you to make diagnosis of these conditions relatively easier compared to the conditions we saw so far. The commonest one is Leigh disease, which is a mitochondrial disorder which happens due to defect in pyruvate dehydrogenase complex metabolism. Hallmark of this disease is symmetric degeneration of puttamina and periaqueductal grey matter, thalami as well as corpus striatum, but asymmetric involvement of white matter, and here is a classic example. So you have this child who used to get recurrent URTI followed by CNS deficiencies. So if you look at this midbrain, there is damage of pars compacta and periaqueductal grey matter, almost looking like face of the giant panda. Also basal ganglia are involved, but you have asymmetric affection of white matter. On MR spectroscopy, you will get a tall lactate peak because of abnormal Krebs cycle. So this is what we look at. So if it was lipid lactate peak, if it was primarily lipid, on long TE spectro, it will not get inverted, whereas if it is lactate, it gets inverted. Next condition which is asymmetric is MELAS. The full form is mitochondrial myopathy, encephalopathy, lactic acidosis, giving rise to stroke-like episodes. Again, in CSF we will have increased lactate like other mitochondrial disorders. Imaging wise, you will have acute infarct-like lesions in the cortex which appear at one place, disappear from there and reappear somewhere else, and they are not bound by arterial boundaries. And here are 2 examples of MELAS. If you see here, there are lesions in both occipital lobes which look relatively fresh because they show restricted diffusion, but no ADC because it is vasogenic edema and not cytotoxic edema. And there are older lesions in both temporal lobes. So they look like infarcts, they don't follow vascular boundary, they appear somewhere, disappear from there and come up somewhere else, and would show lactate peak on MRI and presence of lactate in CSF. Next condition which is asymmetric is glutaric aciduria. This can be diagnosed on ultrasound because of 2 things that we should be looking for. One is turicephaly or tall skull, and 2, bat wing appearance because of presence of frontotemporal atrophy. On MR we look for the same things. In addition, we look for degeneration of caudate and lentiform nuclei which appear bright on T2. Many times, if these hyperintensities are absent, they look like battered baby and you may miss it for non-accidental injury or battered baby syndrome because of presence of widened subdural spaces. Here is another child showing subdural hygromas, frontal and temporal, giving rise to bat wing appearance with lot of atrophy of the brain parenchyma. Then there are certain newly classified ones, and the common one that is seen in our country is Vanderknapp or Agrawal syndrome. This is seen in a specific community who are wanderers, and what we see is, in addition to extensive white matter affection, subcortical as well as periventricular, you get these holes in the anterior temporal lobes. So large head, white matter affection and holes in the temporal lobe is classic of Vanderknapp syndrome. Clinically, for the amount of MR imaging findings, the patients are very well preserved. So they will just have large head, they will have not too much of neuroregression, they are mentally subnormal but not completely abnormal. So that was one case. This is another child who came to us with suspected encephalitis, and we found this. It was not looking like encephalitis at all. So we checked. The child had larger head and kept failing in the school quite often, but not completely abnormal. So you have extensive white matter lesions plus holes in the anterior temporal lobes. As we saw so far, we saw about 16-17 conditions. Majority of them will have white matter affection, white matter affection, and white matter affection. So at times, if patient comes late, many of these conditions can look same, and in that situation, MR spectroscopy can be quite useful not only for diagnosis but also for follow-up. And here are a few examples. Canavans, we saw everything getting affected, but a very tall Na peak. Lays, we saw, look for inverted lactate at 1.3 ppm. In galactosemia, we saw galactitol next to myoinositol at 3.7 ppm. So how do you radiologically approach these 50 conditions that you will come across, out of which, as I said, 15 or 16 are common? So first check the clinical parameters, whether the patient has normal head circumference or large head. Then look at the pattern. If it is central to peripheral, think of metachromatic leukodystrophy and Krabbe's. Then look at age of onset of symptoms. Older child, metachromatic; younger child, Krabbe's. Then look for posterior to anterior pattern and enhancement. You're dealing with adrenoleukodystrophy. Look for skin bronzing and absolutely 100% in males. Peripheral to central pattern, think about Canavans. Onset is infancy. Anterior to posterior pattern, think of Alexander's, large head, onset in infancy, and this will enhance after giving gadolinium. Then there are specific distinctive features of certain white matter disorders. So complete or near complete lack of myelination is seen in Canavans and Pelizaeus-Merzbacher. Frontal white matter affection is seen in Alexander. Occipital white matter affection is seen in adrenoleukodystrophy. Thick enhancing meninges are seen in Hurlers, Hunters, and some of the other disorders. Prenatal diagnosis of these conditions is also possible today. So treatment can be pursued initially, or patient can undergo medical termination of pregnancy. So antenatal screening can diagnose, we all know today, trisomy 21, 18 and 13. It is done between 11 and 14 weeks. If there are certain pointers on ultrasound like holoprosencephaly, myelomeningocele, choroid plexus cyst, ventriculomegaly, and if the fetal medicine specialist is not sure about what he or she is dealing with, MRs in fetal age group can be quite useful. So there are several articles which talk about all these conditions being diagnosed in first or early second trimester of pregnancy, and here are a few examples. Zellweger's can be diagnosed around 20 weeks by looking for ventriculomegaly, large cavum septum pellucidum, small cerebral convolutions, periventricular white matter hyperintensities, and subependymal germinolytic cysts. Joubert's and other similar conditions and variants of these can be diagnosed using fetal MR. Dandy Walker versus Dandy Walker variant can be easily diagnosed and differentiated on fetal MR. Before we end, we'll try and understand what we learned. 6-month-old infant with large head, anterior affection, large head, so Alexander's. 8-year-old male with skin bronzing, posterior affection, so adrenoleukodystrophy. So to summarize, we learnt the genetic classification, pathological classification and imaging classification. For us, as I said, the battery of tests have not happened. MR happens first, so imaging classification is most important for us. MLD by far is the common one that you'll come across. So look for butterfly and tigroid pattern. Krabbe's, look for atrophy and soft calcification. Adrenoleukodystrophy, posterior. Phenylketonuria, remember diffusion weighted images and ADC mapping. MSUD, think of maple syrup smell and middle cerebellar peduncles and cerebellar peridentate white matter getting affected. PMD, subcortical U fibers and newborn like brain. Galactosemia, remember galactitol at 3.7 ppm. Pecan 2, eye of the tiger sign. Menkes Kincaid disease, remember subdural hygromas, tortuous vessels and severe cerebral atrophy. Canavan, remember tall NA. Alexander, anterior. MPS, prominent perivascular spaces. Hepatolenticular degeneration, basal ganglia and face of the giant panda sign. Lays, asymmetric brainstem, basal ganglia and white matter. Melas, infarcts which are not in vascular territory, they appear, disappear from there and appear somewhere else. Glutaric aciduria, subdural hygromas giving rise to turicephaly and bat swing appearance. What we must know is what we learnt holds true in the early stages of disease. End stage imaging in most of these disorders would appear almost the same. So pattern recognition that we learned just now will hold good only in the early stages of disease.